All right, I think we can start at least the housekeeping items. Welcome everyone, and thank you so much for being on time and early this evening. We're super excited to be hosting you tonight. Welcome to Everything You Want to Know About Varicose Veins and Venous Disease with Dr. Daniel Gorin. Dr. Gorin specializes in vascular surgery and is well-versed in all aspects of vascular care. He is focused on minimally invasive techniques and performs state-of-the-art endovascular treatments. Dr. Gorin has a strong clinical interest in outpatient office-based vascular care, and he opened one of the first outpatient endovascular centers in Massachusetts and has performed thousands of office-based vascular procedures. He also devotes a significant part of his practice to the treatment of venous disease, with a particular focus on minimally invasive office-based vein procedures. He performed the first venous closure procedure in Massachusetts, a procedure to treat varicose veins using a catheter under ultrasound guidance, and has personally performed thousands of minimally invasive venous procedures. He has been on a faculty member at multiple courses and symposia on minimally invasive venous care. So thank you so much for joining us, Dr. Gorin. Before we get started, I would just like to remind all participants to please keep your cameras off and your microphones muted as to not disrupt or distract from the presentation. If you do have any questions throughout the talk, please use the chat feature to send it to us, and we will address it during the Q&A session immediately following the presentation. As you probably heard as you entered the Zoom meeting, this virtual event is being recorded and it will be posted to the Cape Cod Healthcare website in about a week. And again, that website is capecodhealth.org/vascular.
Can you close the door?
Now, without further ado, please welcome Dr. Daniel Gorin.
Hi there, Kelly. Thanks so much. So we're going to talk a little bit about venous disease and varicose veins tonight. Now, traditionally, when I trained, vascular surgeons didn't really want to talk about veins. Veins weren't sexy. We wanted to talk about stuff like this. And this is a picture of an aneurysm in an artery in the belly, and those are, the kinds of things that can rupture and are dangerous and people can die from. And we used to do big open surgeries for these, which were really exciting. And now we have a lot of minimally invasive, pretty slick techniques to treat these. But the reality is that most of the people that are listening to this talk don't have an aneurysm, and I'm not going to help them out. But varicose veins are really common. They just have traditionally not gotten any respect in the vascular world. That has changed a tremendous amount in my career because we've now developed really, really good ways to treat people. And varicose veins and venous disease is everywhere. It is really prevalent. And I would guess that the majority of the people that are listening right now probably have at least some amount of venous disease and varicose veins that are there. And they certainly know people that do. Venous disease has been around for a long, long, long time. And I love this slide that I found, which is a picture of a tablet on the west side of the Acropolis in Athens. And you can see a nice big varicose vein that's chiseled into this leg that's there. So this was recognized for a long, long time. So I'm going to sort of give an overview, and I'm really going to focus mostly on varicose veins because that's, I think, what a lot of people kind of want to hear about and understand the real evolution in our ability to treat varicose veins with really minimally invasive stuff rather than the rotten old stripping surgeries that we used to do. So we'll talk a little bit about the causes, a little bit about kind of the anatomy and where it is, but not a medical school talk. Just some definitions because there's lots of words thrown around out there. And then how you evaluate and the treatment. What I'm not going to talk about is a whole bunch of other vein problems that vascular surgeons do deal with as well. So very briefly, you might have heard of deep venous thrombosis or DVT or blood clots in major veins. And we do both the medical care, the diagnosis, as well as treatment of that. Pulmonary embolus is when blood clots break free from veins and go to the lung. And we're involved in managing and treating those as well. We have devices called vena cava filters that we put in to help protect against pulmonary emboli. We see lots of people with swelling of the legs from causes other than vein problems. The most common is with lymphatic problems and lymphedema. We deal with arm or upper extremity problems, something called thoracic outlet syndrome, where the ribs and so on can compress the veins and can cause problems with swelling and pain in arms. So there's a whole bunch of other venous disease that we treat. So I don't want you to just think that we treat varicose veins, but I'm going to focus on that sort of tonight. So causes of varicose veins, they're typically described as multifactorial. And there are probably some environmental factors, and people talk about standing jobs and so on, although I rarely find people that get to, stand on their hands or lie on a couch and work all day. Maybe that's changed with the pandemic, but for the most part, most of us have our feet down. I think that the biggest risk factor that we see is hereditary, and that varicose veins run overwhelmingly in families. 70% will have a positive family history. I did a study when I was a fellow on the epidemiology that we presented, and I think it was closer to 90%. So it's overwhelmingly that family members, if you have varicose veins, you have family members with them. And I joke that if I see somebody who says that they don't have anybody in the family with varicose veins and they have them, they never saw grandma in shorts, because somebody had them somewhere. There are some other things. Age, they definitely become more common as you get older. They are more prevalent in women than in men, although men absolutely get them. Pregnancy is absolutely a risk factor, and a lot of the hormonal changes and so on seem to bring on varicose veins. Obesity brings on venous disease. Certainly, if people are very overweight, it's a problem. If you have a history of blood clots in the veins, you can do that. Believe it or not, really, really tall people are more likely to have varicose veins than short people. So that might be an advantage for some of the vertically challenged folks here. And hormones, particularly around pregnancy and so on, can clearly get involved in this. One of the underlying or common denominators in people who get varicose veins and vein disease is this. Veins in the legs all have one-way valves in them, because there's no pump like your heart sitting in your foot, pumping blood against gravity up your legs. So the body basically uses the muscles in the legs to help kind of squeeze the blood up. And then you have one-way valves in all of these veins. So when the blood goes up, it just doesn't pool back down again. And one of the common denominators in people who develop venous insufficiency and develop varicose veins is that those bad veins stretch out and the one-way valves stop working. They start leaking, so that when folks stand up, blood goes backwards down the veins, and the veins balloon out under pressure, and you walk around with big bags of blood on your leg all day that by the end of the day are often achy and tired and uncomfortable. So just a little bit of anatomy. There's the venous. It's commonly said that veins don't read the textbooks, and there's a lot of variation and so on around veins. But let's divide up veins into a couple of things. When we talk about veins, we talk about the deep veins. Those are the major veins. Those are the ones that are deep down in the leg, and they really do all of the circulation work of bringing blood out of the leg and back up to the heart. Then there are the superficial veins. That's where you get varicose veins. The superficial veins lie, in general, kind of under the skin and outside of all the muscles and so on. And there are some certain ones that have names. The most common and most famous one is called the Great Saphenous vein, and that is a vein that runs from the inside of the ankle up the inside of your leg all the way to your groin, where it empties into the major veins. There's also, in the superficial veins, so you can see the Great Saphenous vein here. There's a small saphenous vein that runs up the back of the leg. And then there's some others. There's something called the Anterior Accessory saphenous vein that goes up the front of the thigh and into the groin and joins the major veins there. The reason that I'm bringing up these veins is because these veins are a big reason why people get varicose veins. And what we will commonly see is that somebody with big varicose veins on the inside of their thigh, in the inside of their calf, has a bad Great Saphenous vein. And by bad, I mean the one-way valves in the vein are broken. So now when somebody with a bad Great Saphenous vein stands up, now all the blood in the really big, or a lot of the blood in the really big veins up in the abdomen and pelvis drains back down this saphenous vein, and all the branches inflate under pressure as varicose veins. And that's a very common cause of varicose veins. And we have a term for it called axial reflux, where we're looking at big superficial veins that fill varicose veins and are kind of the underlying cause of it. That is the vein that used to be taken out in an operation called a stripping. And that was an operation mainly to take out a great saphenous vein where you'd make an incision in the groin, an incision in the ankle. You would pass this thing called a stripper, which was either wire or plastic sort of cord with a little bullet on the end that you tie to one end of the vein, and then you'd pull really hard and pull the vein out of the leg. And it was as great as it sounds. People got all black and blue. They looked like they got run over by a truck. They felt okay, and it healed up, and it worked okay, but it really was not a win. Doctors didn't love it. Patients didn't love it. And lots of patients just lived with their varicose veins. So let's talk about some different terms for varicose veins. And we're going to go from small to big. So small is a term called telangiectasia. People commonly call these spider veins, right? They're the blue veins that live just in the skin. So they're varicose veins. If you could look under the microscope, their walls would be kind of thinned out and the one-way valves in the veins wouldn't be working properly, but they're right in the skin. They describe that, 6-8 feet away with good lighting, you can see them. So people call them thread veins or spider veins. This is some pictures of them. In the front of you can get them in the front of the leg. They're more common lower down on the leg, but you also see them a lot on the outside of the thighs. In general, these are some more. There's another term called a reticular vein, and reticular veins are slightly larger veins, but still blue in the skin, and they'll commonly feed into these clusters of telangiectasias or spider veins. In general, we treat these a lot, but they are not, for the most part, a sign of bad circulation. They're not dangerous. And for the most part, they don't cause a lot in the way of symptoms of pain and so on. We treat them a lot because of they don't look good. They're blue and they're unsightly, and a lot of people want them treated. And we can talk about how we'll do that a little bit later. Then we go to the term varicose veins. Varicose veins are a term that we use to describe the bigger veins that lie just under the skin. So they're not right in the skin, so you don't see the blue that you see in the telangiectasias. They're bigger. They tend to be very tortuous, and these are the ones that are uncomfortable. Because they can get under a lot more pressure, and it's the pressure in the veins that causes the discomfort. So this is a picture of somebody with varicose veins on the inside of their calf and in the front of their lower leg that may very well be coming off of the great saphenous vein that I talked about earlier. This is a picture of somebody that has varicose veins that may be coming off of what we call an anterior accessory saphenous, or a vein going from the groin that goes down the front of the thigh. And then here are these really big varicose veins going over the top of the knee and down into the lower leg. You can see the leg's a little swollen too. Another example of big varicose veins. Now, over time, not everybody with varicose veins and not everybody with one-way valves don't work get these things. But a certain percentage will start to get changes of more advanced venous, what we call venous insufficiency. And that means, again, that the veins aren't working right. The one-way valves aren't working right. And so what happens, these folks are walking around with a pressure in the veins that's much higher than it should be. And over time, that can start to cause damage to the skin and the tissues in the legs. So an early thing that you can see is hyperpigmentation, where you get this brownish discoloration in the skin. They describe it from hemosiderin deposits. In other words, hemosiderin's in red blood cells, and when they break down, this stuff can kind of leak, and then it can get stuck in there. This is an example of what skin staining or hemosiderin staining looks like, and you get this sort of brownish discoloration, usually often in the inside of the ankles. Sometimes it's all the way around the ankles and in the front of the shin. So that's kind of an earlier sign, and you can see this patient has big varicose veins, lots of pressure in the legs, and now is starting to get some skin changes related to it. Then you can get what we call stasis dermatitis or eczema. That's a rash, basically, that is related again to the high pressure in the veins over time, injuring the skin, and you get this itchy, flaky skin and often draining fluid and uncomfortable. This is kind of an example of pretty advanced, where there's that skin colored discoloration, but there's also this inflamed, irritated skin that you get. We often treat these with compression dressings and with steroid creams and so on to clean them up, but the underlying cause is that the pressure in the veins is too high. You can get even worse, where you can get what's described as lipodermatosclerosis. There'll be a quiz at the end of this talk on how to spell that. But basically, that is where the high pressure in the vein starts to actually injure the tissue. So the skin isn't just discolored, but the fat underneath the skin starts to get hard and fibrotic. And these are the patients that can go on to get these sores and ulcers. And this is an example of that. So if you were to feel this area, rather than being nice, soft, normal skin, it would feel really hard and woody. And that's what's called lipodermatosclerosis. And then another term that gets said is called atrophy blanche, where you get this kind of scarring around the area as the wound heals. And you can see in this picture, you've got some of these telangiectasias or spider veins. You've got a little bit of skin staining, and they have this white area, and you can kind of see that it's indented because all of the tissue underneath is kind of fibrosed and it's contracted down into this sort of, hole that's there. It's got skin over it, but it's very fragile. It's very hard. And those can very easily break down with just a little minor bump and result in sort of the most severe part that you see with patients with really bad veins is a venous ulcer, a venous stasis ulcer. And these are sores that people get. They're usually, again, around the ankle, sometimes in the foot, that are related to this. They're superficial. They're uncomfortable. They're a bear to get healed. They take quite a while to heal with dressing changes, and they often recur up to 70% of the time if you haven't addressed the underlying cause of the vein problems that are there. This is an example that I won't leave up long because it's gross, but this is sort of a typical venous stasis ulcer that we see. So what do we do with our folks when they show up? So most of my folks, we'll get, just today in the office, I saw everybody that you just saw. So I saw people that came in with telangiectasias or spider veins that really wanted them treated cosmetically. I saw patients with these big ropey veins whose legs hurt and wanted them treated to make their legs feel better. And we treated patients with venous ulcers that we're doing more advanced treatments on to protect against recurrence. And we're also doing treatments to get their sores healed. So it's the whole spectrum of stuff that we treat. So how do we evaluate people? Well, in part, like any doctor, we try to take a history and a physical and talk to folks. The symptoms that people typically have of just regular old varicose veins, it's not pain. You don't need to take, strong pain medications and so on for this. But typically what people will say is, by the end of the day, my leg is achy. It feels really heavy. It swells. It throbs. It itches. And it's often around the big varicose veins that they feel the symptoms, but sometimes a little more globally. Other things that people will sometimes complain of is restless legs. And we do know that varicose veins and restless leg syndrome go together, and treating the varicose veins will often help with the restless leg syndrome. What other things can you get and show up with this? Well, you can get blood clots in the varicose veins. Now, these are different than the phlebitis or the deep venous thrombosis that I briefly mentioned earlier, that are the ones that can break free and go to the lungs and cause pulmonary emboli and be dangerous. This is where people will get blood clots in the varicose veins. And one of the things that makes blood clot is stasis. If it's sitting still and not moving, it can often start to clot. So with these varicose veins, as I said, the one-way valves aren't working, the veins aren't working, and they're just, for the most part, a bag of blood hanging on your leg whenever your legs are down. So a little minor thing can trigger and get them to clot. And what will happen is the veins, rather than being soft and there, will turn into these hard, red, tender areas. Often people will see them and think they're infected and put folks on antibiotics, but it's really just inflammation from the clot. And they will eventually resolve, but it's uncomfortable. It can be recurrent and happen over again. And it's one of the reasons why we might want to treat these. Another thing that can happen with these is they can bleed. Now, I have never seen nor heard of anybody bleeding dangerously and bleeding to death from a varicose vein, but it can be scary and it can make a big mess. The thing is, again, the pressure on these veins when you're standing up is really high because all the one-way valves aren't working. So if you get thin skin and you get a little tear, then you can wind up with a varicose vein popping open. And if you're standing up, that will squirt a good distance. If you lie down and put your leg up, it drops the pressure in the veins and it stops the bleeding. But I regularly see, particularly my older patients who get thinner skin around the ankle, coming in with bleeding that actually caused them to have to go to the emergency room because they couldn't get it to stop. So that's another thing. So we do exams. We standardly examine patients with varicose veins standing up, because that's how you can see them, and that's when they inflate. If you have people lying down, a lot of times their veins are deflated, which is also why raising your legs and elevating them makes you feel better with them. The most important tool that we have in figuring out people with varicose veins is ultrasound. The biggest thing we want to do is kind of map out with the veins what's broken and what's not. And so everybody pretty much who shows up with significant venous disease and varicose veins gets an ultrasound study. It's a very simple study, and ultrasound uses sound waves to let us look into wherever, and in this case, a leg, to figure out what's going on. And one of the tricks that we have with ultrasound is not only can we look at the veins and sort of see a picture of them, but we can also measure the blood flow in vessels. We can see how fast it's going and in what direction it's going. So by that, we can look at, let's say, a saphenous vein, and we can see whether the one-way valves are working or whether blood is running backwards down a leg. And we can go through and map out, is the great saphenous vein working? Are the major deep veins working? Is the anterior accessory saphenous working? And are those connected to the varicose veins or not? So by mapping that out, we can kind of figure out what are the potential underlying causes of the varicose veins and how can we treat them, which is a big step over, 50 years ago when we just went and stripped everybody's saphenous veins out. And by we, I do not mean me, because 50 years ago, I was not practicing. But so treatment options. Once we figured somebody out, they come in, they have varicose veins, their legs are achy and tired and heavy, and we've done an ultrasound and we sort of figured out their anatomy. How are we going to treat it? Okay. Well, let's start with kind of the conservative treatment. Do nothing. I mean, varicose veins, I always tell my patients when they come in with varicose veins that I never try to twist anybody's arm into having their varicose veins treated. This is very different than somebody who comes in with that aneurysm that I saw at the beginning, which untreated can be lethal. Varicose veins are not. People don't lose their legs from varicose veins. They don't die of varicose veins. Nothing tragic or often happens. They have this dumb, nuisancey, uncomfortable thing that they'll have to live with, but they'll be safe. So the time to treat varicose veins is when they're bothering you. And prior to that, if they're not bothering you, in general, it's safe to sit tight. People talk about compression stockings and leg elevation as ways to treat. And then we talk about interventions and surgery, which is really not an accurate description. It's really just procedures because they're done in the office and they're not surgery. And that's some minimally invasive stuff that we do for certain types of things. So let's talk about the do nothing. I left this slide up for a particular reason because these slides are not mine. They were, and it says do nothing, okay for elderly patients. And I will tell you, first of all, there's no elderly people on the Cape Cod. We got a lot of young 80 and 90-year-olds on Cape Cod. And the majority of my patients that I see with varicose veins are over 65 and on Medicare, and I have treated boatloads of 90-year-olds with varicose veins. And they come to see me because they have these big achy veins that they've lived with forever. I can do this 10-minute minor procedure in the office and make their legs feel better, and with minimal to no risk, and you go right back to your usual activities the next day. So age is not a barrier to having your varicose veins treated in any way, shape, or form. Other things we may factor it in, but not varicose vein patients. Now, yeah, asymptomatic patients are fine. I will tell you as a man that men come in much more commonly asymptomatic than women. And the reason that they do that is that men are not anywhere near as bright as women. And they come in with these big varicose veins, often dragged by their wife. And then they treat them. They have huge varicose veins and I treat them and they come back and say, I didn't know my leg was supposed to feel that good. So most patients, I think, with big ropey varicose veins, like the pictures that I saw earlier, they have symptoms. And it's just, no, they're not in excruciating pain, but their legs just ache at the end of the day. They're tired, they're heavy, and they just don't realize how much better they can feel. Varicose veins do not go away with conservative management. So wearing things like compression stockings and so on for varicose veins is like wearing a truss for a hernia. It makes your leg feel better, but it doesn't make the veins go away. There are medications that you will find, homeopathic medications and things that talk about treating varicose veins. As of yet, there is no identified medication that shrinks away varicose veins. This is purely a plumbing problem, and we as the plumbers can fix it. So There we go. My thing did not want to go forward. Other conservative therapy, weight loss. Yes, morbidly obese people, like the patients who have weight loss surgery, will almost always have problems with the veins in their legs. And if you do an ultrasound, the one-way valves in all of their major veins won't work. And it is interesting that when they have the weight loss surgery and they lose 100 pounds and you go back and check, they're the only people that veins start to work properly again. So they're the only 100% curable vein disease. They talk about other things that I will show you with degrees of skepticism. Exercise is great for your legs. It's good for pumping fluids and so on. It does not fix varicose veins. Varicose veins are outside of the muscle, and they're really not going to make them better. Pain medications. I do not think anybody should have to take pain medications to treat their varicose veins when they're curable with minimally invasive procedures. So you can try Motrin and Tylenol, but if you have to take it regularly, you get things treated. The compression stockings we talked about, the big reason, in all honesty, and I will tell you right now, I don't have varicose veins. I am wearing compression stockings right now. Most vascular surgeons wear knee-high compression stockings a lot, not because it's going to protect us against anything horrible happening to us, but because they make your legs feel better. And I was on my feet all day. I saw 30 patients in the office, and boy, my legs feel better at the end of the day. And when I'm standing doing surgery for 10 hours, they're nice to wear, but they don't make your varicose veins go away. And we do know that patients who have painful varicose veins who note that when they wear a stocking, it helps with the symptoms, that is a really good predictor of patients that will feel a lot better if we treat their varicose veins. And that's been shown in studies. Now, the big thing about stockings is that the insurance companies want you to try stockings before they will approve treating your varicose veins. And most of them are going to want between 6 to 12 weeks of what they call conservative therapy, which means having what they call a graded compression stocking. And the other thing is that they want to hear that your varicose veins interfere with your activities of daily living, like you're shopping, you're working, you're doing things. And they don't mean that you can't do them. It's just that your legs are achy while you're doing them, particularly at the end of the day. So, and that's really commonly what we see. Now, an important thing to tell you about the stockings with the insurance companies is, number one, as I tell folks, I have treated tens of thousands of patients with varicose veins, and I've never one time seen anybody's varicose veins go away after using a stocking for 12 weeks. And there are studies that show the cure rate of stockings and varicose veins is 0%. The other important thing to know is that the insurance companies do not actually say how often you have to wear the stocking. What they do say is you have to have a stocking. So you just need to have it for the 3 months, use it as much or as little as you want, and that will satisfy the requirements of insurance companies, including in Massachusetts Medicare, including in Massachusetts Mass Health, and basically all of the private carriers. So these are an example of stockings. What we mean by graded compression stockings, and in truth, the one in the upper left-hand corner that doesn't go over the foot is not a graded compression stocking. A graded compression stocking means that the stocking is tighter around the foot and the ankle, and then a little less tight in the calf, and a little less tight in the thigh, so that it's kind of pushing the blood up. And that's what a prescription graded compression stocking is. You can get them online. You can get them in the medical supply places in the area. Some offices, we have them available for our vein patients who are having vein procedures to get as well. The vast majority of insurances do not cover these other than Mass Health right now that does cover them. But they're not extraordinarily expensive. And the thigh-high ones are great for procedures. The knee-high ones are great just to make your legs feel better when you're up and around. So that's just a quick overview of the stockings there. So let's talk about treatment. So as I told you, in the bad old days, first of all, we treat varicose veins sort of in a stepwise fashion. So we start out by looking at patients. We'll see a patient, they've got painful varicose veins. We'll get them their stocking and their ultrasound. We'll do the 3-month wait. And then what we'll start out with is say, is there any what we refer to as axial reflux, or what says is truncal veins here? And that means some of those larger superficial veins that I told you about earlier, like the great saphenous vein, the small saphenous vein, the anterior accessory saphenous, one of those larger superficial veins that connects to the major veins is broken and the one-way valves aren't working. So in the old days, we used to strip that vein. We now have ways of treating it that are called endovenous ablation. And that's what that means in general, is that we put a little catheter under ultrasound guidance into the vein and ablate the vein. And usually it's by heat, or there's some other ways of doing it. And it basically causes the vein to shrivel up and go away, rather than yanking it out of the leg like that awful old procedure, the stripping procedure. So there are a couple of different ways of doing using heat, and these are by far the most popular and sort of the most time-tested ways of doing this. One we really like is called radiofrequency ablation, and that uses an electric generator to heat up the vein without heating anything else around, and causes the vein to shrivel up and go away. In my hands, typically this procedure is about 10 minutes. You get a little pinch of Novocaine somewhere around the knee, usually a little bit below or a little bit above if we're treating the saphenous vein. Under ultrasound guidance, through that little numb spot, I thread a tiny needle into the vein, a little guide wire, and then I can thread this catheter. And the catheter, as you can see in the picture, can be anywhere from 60 to 100 centimeters long, depending on how far we have to put it up the vein. You don't feel that because it's inside the vein. Then under ultrasound, we add a little extra local anesthetic, which is people tolerate really, really well. It's not terribly uncomfortable around the vein. That takes about a minute. And then we turn the catheter on, and in about a minute or so, we slowly remove the catheter in a stepwise fashion, and it heats up and treats each segment of the vein. When you're done, you get a Band-Aid, an elastic stocking, you get up and walk home. We tell you to lay low a little bit the day of the procedure, but the next day you can go back to all your usual activities, really without any restrictions, including working out, running. We usually want you to wear stocking for a few weeks while you're up and around. And that's about all that we do. Nobody takes pain medicine afterwards. There's another technique of doing this called laser ablation. It's really the same concept, but rather than using electric energy to heat this vein up, we use light energy. So you use a laser. The older lasers were really, I think, not quite as good as the radiofrequency catheter that I told you about earlier. The newer lasers are probably pretty equivalent in terms of how well they work and how comfortable they are. So all of these techniques, I think, work very comfortably. All of the procedures are 10 to 15 minutes. They're all with a Band-Aid, and there's usually very little to no discomfort afterwards. There are a couple of slightly newer ways of treating the saphenous, these axial reflux veins, that use techniques that don't use heat. So NTNT stands for non-thermal ablation, or non-thermal, non-tumescent is what it means. And that means you don't use that extra Novocaine along the vein. There's the Clarivein, there's the Venaseal, and the Varithena. You may see these advertised and around, so I can tell you about them quickly. Clarivein is something called mechanical chemical ablation. I was involved in one of the earliest trials on this one. Basically, this uses a little tiny catheter that you put in the exact same way that you just saw. The catheter has a little wire on the end with a little motor, so the wire spins around and sort of roughs up the inside of the vein, and then you inject a medication or a sclerotherapy agent that causes the vein to scar closed. So there's that one. There is the Venaseal, and that uses actually a glue. It's a cyanoacrylate glue, which is a similar glue to what is used to glue in artificial hips and so on when orthopedic surgeons are doing this. And this has a little catheter and a guide wire that you put in, and you basically thread it up the same way, and then you dispense little dollops of this glue in the vein that irritates the vein and causes it to scar closed as well. And this is sort of a picture of the Venaseal catheter and sort of how that works. And then lastly, we've got this foam sclerotherapy, something called Varithena, which is a foam that you can inject into the vein and cause that to scar close. So those are the non-thermal ablation things. Now, what do we find when we use any of these? And there are kind of pros and cons of each of them, and I have my own biases. In general, I think you will find that the majority of patients are still treated with the thermal, with either laser or radiofrequency. It has the track record that is the best long term. We know there's 10-year data now out on the radiofrequency ablation that shows it's really durable and safe, and they're quick and easy and comfortable. There are some occasional areas where we'll use the non-thermal techniques as well. They have a little less of as long a track record, but they're perfectly reasonable to do as well. In general, the common denominator is we're treating this refluxing vein. So what we do is we typically will treat folks, and then we'll see them back and see how they do. So we don't touch the worms on the skin, the big veins that you saw in those pictures. We're treating the underlying vein that is feeding and pressurizing them. And what we find is that a reasonable number of my patients get better. They get a lot better. Their legs stop aching, their ankles stop swelling, their varicose veins shrink down. They come back in all excited with a list of 5 friends that are going to come to see me for their varicose veins too. So we have another group of patients that will still have leftover veins or just have what we call primary secondary varicose veins. So we may have some patients that will show up, and we do that ultrasound, and all those major branches I told you all about are fine. The saphenous vein's fine. The small saphenous vein is fine. And they just have clusters of what we call secondary varicose veins, or they're floppy varicose veins, but they're not being fed by any major branch. And the other group of patients that we'll see are people that we do one of these ablation procedures on, and they come back and say, Doc, gee, you know what helped? My leg feels better, my vein shrunk some. But if I've been standing for a while, there's still some places where these varicose veins pop out, and after a while, they still kind of ache. I'd love to get rid of them. Can you do that? And the answer is sure. And mostly we do that with a procedure called phlebectomy. Phlebectomy is also a procedure that we do under local anesthesia. It's done in the office. It has tiny little incisions that you can't see. Some people steri-strip. I don't even do that at all. And it worked great. So this is what a phlebectomy is. Basically, what we do is we have you stand up to get your veins to stick out. In whatever area we're going to treat, we mark on the skin where those are. I have this thing called the vein light, which makes you glow orange so you can really see the veins. Then we have you lie down, we prep the area, and then we numb the area with this stuff called tumescent anesthesia. Tumescent anesthesia is a very weak Novocaine anesthetic that was developed for liposuction. It's great for vein procedures for a couple of reasons. One, you can use a lot of it. It's a lot more comfortable than regular varicose veins, and it's safer, so you can numb a big area of varicose veins, which you can never do with full-strength Novocaine. The other thing is it cuts way down on bruising afterwards, which is why they use it for liposuction. So then over each little cluster of veins, we make a tiny incision. These incisions, we don't even use a knife. We use a little needle to make these incisions. They are maybe a 1/16 of an inch or a millimeter or 2 in size. Remember, when you're lying down and your leg is up, your veins are deflated. And the walls are quite flimsy. So we have these tiny little vein instruments. We can reach in, grab the corner of the vein, tease it through the incision, and remove it. So this is a picture of a little varicose vein that's coming out through the incision. This instrument was not put in through there. It's just used to hold the vein. And you can avulse it. You can just they'll tear apart, and a little piece will come out, and the other pieces will retract and just scar closed. And you just sort of walk your way down the leg, getting each little tiny area. When you're done, you'll have these little tiny incisions that will heal up and really be unidentifiable when they heal. When we're done, we wrap people up in a big ace bandage dressing. The next day, take that off in the shower, put a stocking on, and go about your business. Nobody really needs pain medicine. You get a little mild bruising, but nothing terribly severe at all. And so those two procedures together are what we do with the vast majority of our what we call varicose veins, right? The bigger veins. How about the telangiectasias or the spider veins? You'll find a couple of ways that people try to treat that. You'll find a lot of med spas will try to treat these with laser therapy. In general, if lasers really worked well for spider veins and telangiectasias, I'd have a dozen of them. Most people who buy them wind up using them as a coat rack for venous disease because they just don't work all that well on anything other than really, really tiny little reddish veins in the leg. Most of the big blue ones are too big and they're just not going to do well with laser. I have also seen some of our patients, particularly our Brazilian population down here, that have been treated with varicose with laser that's taken the color out of the skin and left whitish marks on their legs. So I think I would urge caution in considering trying laser therapy to treat telangiectasias or spider veins. What we use a lot of is what's called sclerotherapy, and the regular term for that is vein injections. And that means injecting a medication into the vein that injures the lining of the vein and causes the vein to scar closed. Now, why do we do this on these spider veins or telangiectasias? Why don't we do phlebectomies and so on? Well, the veins are right up in the skin and we can't take out with it taking skin off, and we really don't want to do that. So we need to treat them where they are to lighten them up and make them better. So we do a lot of vein injections for these. There are a number of different medicines that are out there that people use. In the bad old days, people used to use what's called hypertonic saline. It's a concentrated salt solution. I don't know anybody really using it regularly anymore. It worked okay, but it wasn't a really good sclerosant. And it really stung when you injected it, and it caused a lot of leg cramps afterwards. So that's kind of a historical sclerosant. There are three medications out there that people use now. The top two are called sodium tetradecylsulfate, or STS. I don't know why the typo says STD. And then polydocanol, or Sclera, is another one. Those are both FDA approved specifically for vein injections. They're both chemically or detergents, basically. And then there's glycerin. Glycerin is the most common sclerosant actually used in the world for spider veins and telangiectasias. For me personally, it's my favorite. The problem with the detergent sclerosants, which work pretty well, is they provoke a pretty good reaction. And about 10% of patients will get kind of this brownish skin staining in the areas of the veins that were injected, which should lighten up, but can take months and months to fade away, whereas glycerin, it very rarely happens. All three of them do work well. You can also, with the top two, the detergent sclerosants, you can turn them into a foam. If you just basically slosh them back and forth with air or carbon dioxide within a syringe, you can turn them into a foam because they're basically soap. And for slightly bigger veins that you may want to inject, you can do that and it will fill the vein better. We do that on certain cases where we'll do bigger veins under ultrasound guidance and inject them, or slightly bigger reticular veins that we think are a little too big for glycerin. So there's some different roles for that. And whoever you see who's a phlebologist and takes care of venous disease will kind of gauge what medications they use based on what they're treating. But this is an example. Typically, when we're treating the little telangiectasias, we use a tiny, tiny needle. It's a 27 gauge needle. It's smaller than a flu shot needle. You almost can't feel it at all. And we go and inject the medications into the veins. We do that visually. We usually have a headset that actually has polarized light. So it's like for us Cape Codders wearing our polarized glasses on the water so that we can see fish because it cuts down on the reflection. And it's magnified so you can really see the veins. So you go inject all the veins that you're going to treat. You go right into a prescription elastic stocking that we'll want you to wear for a couple days to give a little compression, but you can walk right in and out. There's no pain afterwards. There's no restrictions and so on. And those work pretty well. So that's kind of a quick tour of the different things that we do for varicose veins. And I'd be happy to answer questions if folks have them.
Great. Thank you, Dr. Gorin. Yes, if anyone does have any questions, if you wouldn't mind just using that chat feature at the bottom of your screen, give some time to type them out. Or one question here, can you wear the compression stockings through the night?
The answer is it's perfectly safe to wear stockings through the night. Unless you sleep in a chair with your legs down, you really don't have to, because if your legs are up, then that's sort of taking care of the problem. So you can take them off whenever you're going to kick your legs up. The time to wear stockings is when your feet are on the floor.
Okay. Another question here. What's the recovery time on the phlebectomy procedure?
Yeah, the recovery time for all of our procedures is almost immediate. So if you're talking about a recovery time in which you can drive, work, and basically go out to dinner, square dance, whatever you want to do, it's really the next day. You should be able to do that. We have patients that'll go for a run, do whatever, work out, whatever they want to do. The things that you'll want to watch are you will have some bruising and so on a little bit. So if people say, I'm going to my granddaughter's wedding and I want to wear a dress next week, I would not have a phlebectomy before because you're going to have little bruising and so on there. And that's true with any of the stuff that we do. The one other thing is that you really should watch the sun. And the one thing that makes little incisions and scars get really discolored is if you're suntanning. So if somebody is getting either sclerotherapy or phlebectomy and then goes to Aruba for a week and has their legs out in the sun, those areas are going to turn kind of red and they're going to take quite a while to lighten up. So that's it. But other than that, you can go about your business very quickly.
Another question is what are her meningiomas? Sorry, that screen just moved on me, and I apologize if I butchered that, Dr. Gorin.
Hemangiomas?
Correct.
Yeah, so a hemangioma is just I hate to use the word tumor because that makes it sound like a scary and dangerous thing, but it is a skin lesion that is vascular, so it's got veins in it. So it's often something that you're born with and congenital. They're not dangerous. If they're unsightly or bothersome or get nicked and bleeded, we can do a little excision and remove them. You sometimes see them in babies and they'll often regress on their own. You can also get hemangiomas in other areas, for example, in the liver. You can see them. And a lot of times they're just things that we see on x-rays. We don't have to do anything about them. The hemangiomas I was talking about earlier would be ones in the skin.
Great. Another question, any threat of blood clotting with the phlebectomy procedure?
Yeah. So if you look at the two procedures that for bigger varicose veins, the endovenous ablation, so that's the radiofrequency ablation and the laser and the Varithenas and all of those things, there is at least a theoretical and a small risk of developing blood clots or what's called a DVT. Now, real blood clots are quite rare. I have done well over to probably 15,000 of these. We check every single one of our patients the week after with an ultrasound, and I've seen 2 blood clots, both of which we treated with blood thinners and went away very quickly. So the chances of a dangerous one while they're there are pretty unusual. Occasionally there's a thing that is called EHIT, EHIT, and that stands for endovenous heat-induced thrombosis. And that's a term that came up with something that we saw when we all started doing this really, really early. So we would put the catheter in the saphenous vein. We would get it to pretty close to the major vein, but back about an inch or so. And then we would treat the saphenous vein with it. And every once in a while, when we rechecked, there was no blood clot in the major veins, but there was a little bit of clot in sort of the stump of the varicose vein that was left, or the saphenous vein that was left. And at first there was a big worry that, oh my goodness, that's going to turn into a DVT. That could be dangerous. And early on, we treated everybody with blood thinners for a month and watched them, and it all went away. And later on, we learned that, you know what, most of these, almost all of them go away anyway. And actually, if you think about it, when we used to do the old stripping procedure, we would go up to the same place and we'd do a suture ligature around the vein. And if we had checked them with an ultrasound, they all had clot in them. And that isn't clot that's going to travel anywhere. It's just kind of clot in the end of that vein. So, we think that that's pretty safe. So the short answer is that blood clots after superficial vein procedures are theoretically possible, and they're very, very, very unusual.
This person asked, if the person is on a blood thinner, how long do they have to be off of them?
Right. So it depends on what you're going to do. In general, the first procedures, these endovenous ablation procedures like the Venefit one and so on, we actually regularly treat patients on blood thinners with that. So we don't stop them. And it seems to be safe, and the veins seal off just fine. If you do a phlebectomy, you do want to stop your blood thinner because you'll get a lot of big bruises with that. And so depending on what blood thinner it is, And then it would be how long you need to stop it. If you're on warfarin or Coumadin, that needs to be held a little bit longer because it takes longer to wear off. If you're on what they call the DOACs or the new anticoagulants like Xarelto and Eliquis and so on, you usually can stop those for 36 hours. And that would be something that you would want to talk to, whatever physician's treating you to determine that, because we would factor into why you're on it and to what the risk is of holding it a short period of time. But almost always people can be treated and it's safe to hold for a brief amount of time. And we can always start the blood thinners right back on up.
How often can you be treated? This person has had treatment done in the past. Would they need to bring records from the other procedures?
Yeah, records are always nice, but they're really not all that helpful, frankly, because, we treat every patient with recurrent varicose veins just like a new patient. The question is, all right, and, as I said, right, everybody with varicose veins has the genes to make varicose veins. So I may see you, I may treat everything there, and 5 years from now, a couple of veins in your legs that were working perfectly fine stretched out, and now they're not working and they're varicose veins. Now, by treating patients with ultrasound guidance the way we do and knowing what's going on when I see patients, that cuts down on the recurrence rate a lot. So if you look at that, again, the radiofrequency ablation procedure that I told you about, the Venafit procedure with the catheter that we ablate the vein on, when we started doing that, it was actually called the venous closure procedure about 20 years ago. Their data showed that if you treated that vein and followed people for 5 years, 85% of patients were still symptom-free and doing great in 5 years. So that's pretty good. But a subset of patients will recur. When they come back with new varicose veins, we're going to start from ground zero, because we're going to say, well, why do they get new varicose veins? We need a new ultrasound. Do they have a new vein that's refluxing now that was working normally, like their small saphenous veins no good now, and we need to treat that? Or are these just secondary varicose veins that just kind of dilated up and we can do a phlebectomy on them? So the answer is we don't need the old records. We can sort you out just fine by seeing you. That's not a problem.
Great. This person asked if both legs need TX. Is that done in one visit?
I'm sorry, if patients need which?
They wrote TX. I'm wondering if treatment.
Oh, okay. Yeah. So the short answer is that I don't know anybody who is seeing a patient and treating them on the same day. And there's a couple of reasons for that. The biggest reason is that the insurance companies won't let us do that. They want to have patients seen. So usually the way that we do this, and, I tell patients, think about treating venous disease as something that's a stepwise thing. We're going to do little simple things that should not disrupt your life in any meaningful way until we get to a point where you're good. So we'll start out and see you and examine you and talk to you and see what's going on. I will see patients that come in with what they think are varicose veins. Saw somebody today, and the reason that their leg hurts is because they have an artery blockage. Or I see somebody else who clearly has a herniated disc or a problem in their back, and that's really the problem. So you really want to be seen and assessed first and see what's going on. Then we will look and get you in for an ultrasound, which we'll do quickly, if that's appropriate, which commonly it is, but we're going to decide that, and we're going to make sure that we do the right ultrasound. Because a lot of if you just go get an ultrasound somewhere, they won't tell you all the information that we need to treat varicose veins. They'll commonly do an ultrasound to just see whether you have blood clots in your legs, which is the most common reason why vein ultrasounds are done. So then we do that. Now we know what's going on. In the meantime, we're also making sure you have your stockings, and we're jumping through all of the hoops that you need. So insurance will allow you to be treated. And then we can go, and if you have a bad saphenous vein, let's say, we treat that and see how you do. A lot of patients come back and say, my leg feels great, I'm done. And then some patients come back and say, my leg feels better, but I have some extra stuff that I want you to treat, so we can do a phlebectomy. And then people may come back and say, wow, you fixed all that stuff. I hate the blue guys on the outside of my thighs, those spider veins. Can you do vein injections and treat those? So, and we may not do all of that on everybody. It depends on what they have. So it's a stepwise thing to really treat. It's not sort of a come in one day, we treat everything. We're not going to do a good job. And we want patients to get a really nice result and get exactly what they want.
Can you please explain the term scar closed a little bit more?
Scar, okay. Well, scarring is the way anything heals, right? So if we're going to take a vein See, the challenge, let's say that I have that big saphenous vein that we talked about, and we're going to try that we used to remove by stripping, and now we want to what we call ablate it. Okay, I don't want to clot it. If I put something in that just injures it and causes it to clot, then you're going to get that superficial phlebitis I talked about. That vein is going to turn into this painful, hard, red knot in your leg that will take months and months to go away. We want to cause the vein to heal closed. So we want it to kind of shrivel up and turn into a tiny little piece of scar tissue that you'll never be able to find. So by injuring the lining of the vein and causing the vein to shrink around the catheter or around the sclerosant that we inject, it depends on what we're treating, we're going to cause the vein to do that and basically seal closed in a tiny little thread rather than being this big vein.
Excellent. This person wants to know how far out is our office booking appointments. I don't know if Dr. Gorin, you know that answer.
The short answer is I don't know, but we are really, we're really good about getting people in. We want patients to not wait around, and we treat, not just with veins, we treat patients with things that are more life and limb threatening. And we have doctors in the office every day, and we're accustomed to getting people in so they can get taken care of. That's what we do.
Yes, you can request an appointment on our website if you'd like. Or call us directly. So
yeah, and I will say that one thing we pride ourselves in our office is human beings answer the phone. So you'll get somebody to talk to, and we'll work with you on what you need.
Excellent. All right, this person has asthma and they've had varicose veins for years, not Medicare age, but wondering if the risk is opting to go through an elective surgery. Should they first have a visit with you? They've seen their PCP for clearance anyways, but this has kind of always been on their mind.
Yeah, I for the most part, I would not hesitate on treating patients with asthma at all. The one thing that they talk about a little bit is the potential, and I think it's frankly overblown but with some of the detergent sclerosants and the concept that you could have that could trigger asthma. With glycerin, which is what we usually use, I've never seen or heard of it. Glycerin is just a sugar. But for all of the bigger varicose veins that we do, asthma is a non-issue. There's nothing involved in that would concern us at all. So I would not hesitate to come see a vascular specialist and take a look and talk about it, because we treat lots of patients with pulmonary disease, heart disease, all kinds of things, and we can treat them very, very safely with this.
Okay, great. This question: does removing large veins cause circulation problems?
If we're talking about treating the varicose veins, and this is the quick answer is no. When we're treating patients with varicose veins, the veins that we are treating are not doing anything helpful for your circulation at all. They're not working. So when you stand up, it's not that blood is going up these veins and going back to your heart the way it's supposed to go. They're just bags of blood hanging on your leg. They're not functional at all. And if you really kind of move on down the line, they're actually making your circulation worse, because they're increasing the pressure in your vein system in your legs higher than it should be. So you're walking around with elevated pressure, what we call venous hypertension. And that's the thing that can go on to cause the skin changes and the ulcers and so on. So by getting rid of these abnormal veins, we actually make your circulation better. Now you can remove superficial veins that are completely normal and not hurt circulation at all. So the saphenous vein, that great saphenous vein, is a vein that I will commonly remove and use to do a bypass in the leg, and our heart surgeons will use for heart surgery bypasses. That's a common thing that we use. Now, when it's a big varicose one, it's not any good to use for that. So it's not a problem. And it's been pretty well studied to look and say, is there a problem with treating varicose veins if somebody needs a heart bypass later? And the short answer to that is no, it's not a problem at all. You should treat the abnormal veins if they're symptomatic, and it's fine to do. So the quick answer is we likely make your circulation better. We certainly don't make it worse.
And this question here: does insurance cover spider vein treatment?
The short answer is no. That's the one section that they don't. And I think it seems fair and appropriate because they do cover the symptomatic varicose veins, which are, which we're treating for pain and swelling and so on. And the reason we are treating the telangiectasias overwhelmingly is because of how they look. So, I will have patients that come and see me because their legs hurt and they think they're worried that it's their spider veins. And we usually find some other cause for their leg pain. It's not going to be the spider veins. And I wouldn't want to sell them a bill of goods that I'll just inject your spider veins and your legs will feel better. We can make them look better with those. But if your legs are hurting and you just have spider veins, it's going to be from something other than your varicose veins.
Okay. And with that, that is all the questions I have here. Thank you again, Dr. Gorin, and thank you to everybody who logged on tonight. If you joined late or had to jump off and come back on, this recording will be posted to the Cape Cod Health website in about a week, so you can check back there. But if you have any additional questions for Dr. Gorin, we can definitely, he's available at our Hyannis office if you want to give us a call or anything like that. So thank you guys so much and enjoy the rest of your night.
Thanks, guys. Appreciate your time.
Thank you.
Thanks, Carly.
Thank you.